As a member of the panel, you'll consider 7 research topics that were selected by an advisory board of patients, clinicians, and researchers. The information provided in this module for the P-Scanner Stakeholder Research Prioritization Panel serves as a general introduction to heart failure and the current state of the science in each of the 7 topics. You may view this entire presentation all at once, or once you're in Expert Lens, you can jump right to the section that covers each research topic using the embedded links. Heart failure happens when your heart is not pumping enough blood and oxygen, as well as it should, throughout your body. This diagram shows a cross-section of the anatomy of the heart as if you're facing a mirror or another person's heart. In the green circle, we see that the heart consists of 4 chambers. The upper chambers are the right and left atria. The atria receive and collect blood, and the lower chambers are the right and left ventricles, which pump blood out to other parts of the body. There are valves, which are tissue flaps that control the flow of blood through the chambers of the heart. In a well-functioning heart, strong muscular walls contract or squeeze to pump the blood. When the muscles relax, blood collects in the chambers. A heartbeat consists of both a contraction and a relaxation. In heart failure, weakened heart muscle walls cannot efficiently pump enough blood to meet the body's needs. Heart failure does not mean the heart has stopped working or is about to stop, but heart failure is a serious condition that requires medical care. There are different types of heart failure. In left-sided heart failure, the heart can't pump enough oxygen-rich blood to the body. There are 2 types of left-sided heart failure. Systolic heart failure is when the left ventricle loses its ability to contract or squeeze normally, leaving the heart unable to pump with enough force to circulate blood properly. And diastolic heart failure is when the left ventricle loses its ability to relax normally. The stiff heart muscle is unable to fill with enough blood during the resting period between each beat. Right side heart failure, on the other hand, occurs when the heart can't pump enough blood to the lungs to pick up the oxygen. So, what causes heart failure? Heart failure is the result of any number of diseases or activities that affect the heart. Some of the conditions that can damage or weaken the heart and cause heart failure are shown here. For instance, coronary artery disease, including heart attacks, is the most common. Cardiomyopathy, chronic heart disease in which the muscle is abnormally enlarged, thickened, or stiffened. Hypertension, or high blood pressure. Excessive use of alcohol. Use of illicit drugs such as cocaine. Cardiac arrhythmias, irregular heart rate or rhythm. Myocarditis, an inflammatory disease of the myocardium, or the heart muscle. Disease of the heart valves. Valves are the tissue flaps that regulate the flow of blood through the chambers of the heart. And finally, congenital heart defects, a variety of malformations of the heart and/or its major blood vessels that are present at birth. A diagnosis can only be made by a qualified healthcare professional, but individuals may notice certain signs and symptoms of a medical condition in their own bodies. Common signs and symptoms of heart failure include shortness of breath, which might feel like you can't take a deep breath or catch your breath. Fatigue or tiredness. Unexpected weight gain with swelling in the legs, ankles, feet, or stomach. And arrhythmias, which are irregular or abnormal heart rhythms. An individual might notice one or more of these symptoms, but might not realize these symptoms are related to heart failure. This is why it's so important to pay attention to your body and contact your healthcare provider about any of these symptoms. Heart failure is a serious concern in the United States. Information from the Centers for Disease Control illustrate its seriousness. 5.1 million people are living with heart failure. Half of the people who develop heart failure die within 5 years of diagnosis. Heart failure was a contributing cause of 1 in 9 deaths in 2009. Heart failure costs the U.S. $32 billion each year. In the year 2000, there were 1 million hospitalizations for heart failure. Among those hospitalized, more than half of them were patients 65 to 84 years old. Fast forward to 2010. While the number of people hospitalized with heart failure has remained the same, the distribution of ages has changed substantially. Now, more hospitalized people are younger than 65. Heart failure is the most common reason for hospital admission for patients over the age of 65. Hospitalization is certainly necessary for some patients, but being in the hospital is burdensome to patients and worrisome to their family members. A hospital readmission is defined as an admission to the hospital within a specified period of time after discharge from the same or another hospital. The Centers for Medicare and Medicaid Services, referred to as CMS, track readmissions for 30 days after discharge, but others track for as long as 6 months. Approximately a quarter of patients hospitalized with heart failure are readmitted within 30 days of discharge. More than half of patients hospitalized for heart failure are readmitted to the hospital within 6 months of discharge. High-quality healthcare focuses on keeping patients as healthy and in control as possible, so they don't have to be admitted to the hospital in the first place. Some readmissions are unnecessary or avoidable. The number of avoidable or unplanned hospital readmissions is one indicator of quality in outpatient healthcare services. Healthcare organizations are looking at how to prevent the avoidable readmissions to reduce the burden on patients and families. In addition, CMS, which provides health care insurance for the elderly, poor, and disabled, decided in 2012 to reduce payments to hospitals with excessive readmission rates, so there's also a financial reason to prevent readmissions. Because urgent readmission to hospitals is commonly used to measure quality of care, hospitals are most concerned about the proportion of urgent readmissions that might be avoidable. In one review on readmissions, the authors found that less than 1 in 4 readmissions were deemed avoidable. At this point, you may continue to listen to the presentation on all 7 possible research topics, or when you're in Expert Lens, you can click the link next to each topic and jump right to the section that covers that research topic. For each topic, we provide key definitions from current research and a brief overview of important points from current research to think about as you consider the topic. Topic 1. Understand whether and how care coordination activities impact patient outcomes. Patients with heart failure often have multiple providers involved in their care, such as primary care physicians, cardiologists, nephrologists, nurses, etc., family members and friends who assist with daily activities, and community services they use. All of these participants make up a person's care team. Care coordination of a patient involves organizing care and sharing information among all of the participants to achieve safer and more effective care. Some examples of care coordination activities are organizing numerous visits in an efficient way for patients and clinicians, visits to multiple care teams, which also require lots of coordination, communication and sharing of important medical data among these care teams, discussing and developing a comprehensive plan of care among all care team members, this is critical, proactively tracking signs and symptoms that can be early indicators for changes in treatment, advanced care planning to assure how to handle medical decision-making and end-of-life issues. Vulnerable phase for care coordination. The time period after hospitalization, at around 2 to 3 months, is the vulnerable phase, when there's a particularly high risk of poor outcomes. Research has started to focus on this period when the patient's care is in transition. More attention is being paid to the quality of planning and education just before a patient is discharged, as well as monitoring care and health status after leaving the hospital. Some strategies include patient education, collecting data like symptoms and daily weights, and early contact with the healthcare providers in the home or clinic setting. Limited evidence-based strategies exist. Currently, there's limited evidence about how to reduce risks after discharge. Many of these kinds of studies are small and limited to one center for study. There is a need for care coordination and advanced care planning earlier in the care of heart failure, even at the time of diagnosis. Topic 2 compares different approaches to lifestyle changes, such as nutrition, physical activity, stress reduction, and symptom self-management, like fluid retention, fatigue, mood, alone or in combinations, to determine which strategies are most effective. Lifestyle changes. What is lifestyle? Well, when we say lifestyle, we refer to those regular activities that individuals engage in that they can control. Since heart failure patients need to manage their condition on a long-term basis, many treatments and therapies also rely on patients to make overall lifestyle changes, such as limiting salt and fluid intake, monitoring weight, engaging in physical activity, and fostering healthful sleeping habits. Symptom management. A patient with heart failure will probably be prescribed numerous medications to avoid fluid overload, treat hypertension, and help with heart and blood vessel function. Some patients who develop heart failure show minimal symptoms, whereas others have distinct symptoms like shortness of breath, even with minimal or no exertion. Some patients accumulate excess fluid and salt that appears as swelling in the legs or belly or fluid in the lungs. Awareness of possible symptoms and knowing how to manage them before they worsen is crucial for symptom management. Distinguishing the effects of lifestyle change and self-management from other aspects of health interventions. With heart failure patients, making lifestyle changes and learning to self-manage symptoms are often necessary strategies, regardless of the therapy being delivered. Most research studies of lifestyle changes and symptom self-management in heart failure patients include many different components, all of which must be addressed. For example, one current study is looking at the effectiveness of an intervention that includes education while the patient is still in the hospital. After discharge from the hospital, the patient's vital signs and symptoms continue to be monitored remotely, and they receive continued health coaching by a nurse over the phone. This helps prevent additional hospital admissions. One challenge that studies such as this face is figuring out how effective the lifestyle changes are due to the remote monitoring and from the follow-up coaching calls or at-home visits. Overall, while studies show results of long-term self-care education with frequent reinforcement have produced significant decreases in hospitalization, mortality rates have not been reduced. Quality of life and other patient-centered outcomes. While many studies are concerned about quality of life for patients with heart failure, there are few studies that include other patient-centered outcomes related to lifestyle change and self-management. This may be in part due to not recognizing outcomes that are most important to patients. Topic 3. Compare different lifestyle change support strategies such as health coaching, individually tailored health messages, or communications with clinicians, alone or in combinations, to determine their effect in maximizing health outcomes for individuals with heart failure. The focus on this topic is defining behavior change strategies that look at behaviors affected by one's conscious decision-making. First, what's a health coach? Health coaches support patients by helping them set goals, overcome barriers that might prevent them from achieving their goals, and motivate them to stick to their new lifestyle changes. Health coaches can be nurses, medical assistants, or even other patients who've successfully managed their own condition and are now trained to help others. Okay then, what's an individually tailored health message? These are customized messages sent to patients regarding their health, depending on specific situations, and they might contain reminders, advice, or instructions. Often these require technology to access, such as mobile phones, email, and other mobile applications. The last strategy, communication with clinicians, such as physicians, nurses, pharmacists, and others, can happen in a variety of ways, but typically this involves one-on-one, in-person conversation. This might also occur during follow-up phone calls, by email or other technology, or in-group visits. Recognizing both positive and negative results from lifestyle change interventions. There have been studies looking at health coaching conducted with patients who have chronic conditions. Some have shown that health coaching can potentially improve healthy behavior and long-term health. Others have not shown beneficial results, highlighting how difficult it is for patients with serious health conditions to make lifestyle changes. Telephone-based health coaching for lifestyle change. A few studies relating to patients with heart failure have used telephone-based health coaching. But otherwise, the use of technology is rare. Almost no studies have been conducted for other potentially beneficial strategies that use technology, such as mobile phones, mobile applications, and email. Topic 4. Compare the effectiveness of remote monitoring and telehealth strategies for heart failure. Management of heart failure outside the hospital or doctor's office is a key aspect of treatment because individuals spend very little time in the doctor's office, and most of it in their own homes and workplaces. Telehealth involves the use of electronic information and telecommunications technologies to support health care, health education, public health, and health administration. What kind of technologies are we talking about? Technologies include video conferencing, think Skype, regular telephone-based communications, and even systems that store images, like X-rays, and send them to other locations, streaming media, mobile applications, and other systems that use the Internet. And remote monitoring? Well, this involves collecting and transmitting patients' physiological data outside conventional clinical settings, such as while in their home, using modern technology. Remote monitoring might combine several technologies, including sensors, applications, and text storage sites. For remote monitoring to work, it usually requires a wireless or Wi-Fi connection. Care in the home. In some cases, care provided by nurses to patients in their homes resulted in fewer hospitalizations and fewer emergency department visits, and the patients believed their quality of life improved. Telehealth. A study of veterans found that telephone and videophone consultations after discharge were beneficial in extending the length of time before a patient was readmitted to a hospital. Even though the rate of readmission remained the same, as did mortality, patients' quality of life was much improved, a big bonus. Remote monitoring. In another large study, remote monitoring reduced the risk of both heart failure-related hospitalizations and hospitalizations due to any other cause. Another study, in which patients reported symptoms and weight over the phone to an interactive voice, found no difference in either hospitalizations or mortality as compared to those patients who did not receive telehealth. Which patients, which technology, and how long? Researchers agree there's much still to learn about the potential of telehealth and remote monitoring to affect heart failure outcomes, but this approach raises several questions. Which individuals with heart failure might receive the most benefit? Which are the best technologies to use? And how long and how frequently should telehealth and remote monitoring be used? Topic 5. Understand the balance between patient-centered outcomes and the patient effort required to achieve them. Here's an example from a patient's perspective. Is a 1% reduction in risk of readmission worth an extra day in the hospital, an extra clinic visit during the next week, or entering vital signs and symptom data for a month? Treatment burden. This is the effort and activities that patients perform to undergo treatment and respond to the recommendations of their healthcare provider. The burden also includes the impact that these activities have on the patient's functioning and well-being. Treatment benefit. This is the resulting benefit to health. Number needed to treat, or NNT. The number needed to treat is the number of people who'd need to receive medical therapy in order for one person to benefit. NNTs well above 10 or even above 100 are common. Number needed to harm. And this is the flip side, or the number of people who'd need to receive some sort of medical therapy for one to be harmed. Research helps to describe and quantify the treatment burden and treatment benefit. The results of clinical research trials that compare the effects of various therapies are needed to calculate the number needed to treat and the number needed to harm. Continuing with this topic, we're still trying to figure out how much treatment burden patients might be willing to accept to prevent readmission. What kinds of interventions are patients willing to be responsible for to improve their symptoms? Example of implantable cardiac devices. Strong evidence shows that implantable cardiac devices, ICDs, improve survival. That's the good news, but ICDs require surgery, regular monitoring, and have the potential for erroneous shocks and other disruptions to life. Little evidence is available showing the impact of ICDs on health-related quality of life. Example of taking pills. One study found 70% of participants were not willing to trade any amount of time to avoid taking a preventive pill every day. But on average, they were willing to pay nearly $1,500 to avoid taking a pill daily. So, time was more valuable to patients than a certain amount of money. Let's take another example, say aspirin treatment. In order to see the benefits of aspirin treatment and how it can prevent one additional heart attack over a 2-year period, 2,000 patients need to participate. 2,000 patients before one prevention can be duly noted. This means an individual has less than 1/10 of 1% chance of seeing a benefit with treatment. The number needed to show harm for a major bleeding event from aspirin therapy is 3,333. So, for every 3,333 people who take aspirin for 2 years, one additional person will have a major bleeding event. There's a small chance of benefit and an even smaller chance of harm from a major bleed. In conclusion, patient-centered outcomes need to be taken into account, balancing the treatment burden with the treatment benefit. In order to develop effective interventions, we need to understand the outcomes that are important to patients, mindful of the potential treatment burden as well as the treatment benefits. Topic 6. Compare patients' views and attitudes on vitamins, other supplements, and prescribed medications regarding their heart-related wellness. Vitamins. Vitamins are compounds that are necessary for normal growth and nutrition, and because they can't be made by the body, vitamins can be added to the diet in small supplemental quantities. Supplements. A supplement is a product taken orally that contains one or more ingredients, like vitamins or amino acids, and that's intended to supply something that is deficient in the body. Prescribed medications. A prescription medication is a drug that's available only with a written order from a physician. Interest in vitamins and supplements for well-being. Most physicians consider prescribed medication to be the mainstay in the management of heart failure. Many people are also interested in how vitamins or supplements might help with heart disease and general well-being, and may be taking these without the knowledge of their clinicians. Little research on vitamins and supplements. Some vitamins have been studied for heart disease and found not to be beneficial, vitamin E for example. And some may even be harmful, beta-carotene for instance. But there's little research in this area overall. Topic 7. Understand and identify the predictors of heart function deterioration. Cardiomyopathy is defined as the measurable deterioration for any reason of the ability of the heart muscle, or myocardium, to contract. Cardiomyopathy may lead to heart failure. Individual rates of deterioration vary. Some people with heart failure do well for years, whereas others decline in their functional status quickly or recurrently. A patient's functional status doesn't always correlate well with measurements of heart pump function. Basically, we're not sure what signs are more important than others to tell if the heart's function is getting worse. Predictors of survival. There are a variety of survival predictors that have been identified in patients with heart failure. These include VO2 max, which measures the maximum rate of oxygen consumption. The New York Heart Association, NYHA, uses a functional classification system based on the severity of symptoms. It places patients in one of 4 categories based on how much they can do during physical activity. A 1 indicates a patient has no limitation on his or her physical activity, and a 4 signifies a patient is unable to do any physical activity without discomfort. And there are 4 classes of objective assessment of disease. An A says there is no objective evidence of cardiovascular disease, no symptoms, and no limitation in ordinary physical activity. But a D says there is objective evidence of severe cardiovascular disease with severe limitations. D people experience symptoms even while at rest. Left ventricular ejection fraction, or LVEF. This measures the percentage of blood leaving your heart each time it contracts. Although these indicators correlate with survival on a statistical basis in a large population, their ability to predict survival in individual patients is limited. Thank you for joining us on this adventure to improve the efficiency and relevance of research that we hope will lead to better health for all patients.